Okay, welcome everybody. My name is John Orloff. I'm Chief Medical Officer at Novartis, and I'm a member of the forum, and I want to welcome you to the session on infrastructure needs. You have this session objectives that are listed in your agenda, but let me briefly highlight what those are. We're going to be touching on infrastructure needs and barriers in order to facilitate the conduct of LSTs. We'll be spending a fair amount of time on electronic health records as a platform for LSTs and how that can help us to merge the concepts of delivery of healthcare with clinical research. And then we'll get to establishing and sustaining trial networks as an infrastructure to host and facilitate LSTs. Before I go on to introduce our panelists and our presenters, let me take a few minutes and the chairman's prerogative to share some of my own perspectives from the industry side of things at a very high level. In the industry, we talk a lot about large, simple trials, but we rarely do them. In fact, I think we had a hard time finding an example for this session that was held yesterday. And why is this the case? Why aren't we doing more LSTs? And I think the answer is complicated. It's multifactorial. And in many ways, we're our own worst enemy by complicating or overcomplicating our trials. You'll hear later on today in this afternoon session on complexity and simplicity from Ken Getz and others. Ken has published through the Tufts Center some data showing a remarkable increase in the total procedures per trial, about 50% in the last decade, and more than 50% increase in eligibility criteria, which clearly is a trend in the wrong direction in the spirit of trying to simplify trials. Another study published by Cutting Edge Information found a 70% rise in the per patient clinical trial costs associated with the increase in complexity and the infrastructure costs related to supporting trials. This is over a 3-year period from 2008 to 2011. So while there are a lot of things that contribute to the fact that industry and other stakeholders are not conducting LSTs, I believe that one of the biggest barriers is actually the infrastructure needs and the costs associated with them. So from my view, we're stuck in an outmoded, antiquated business model for conducting clinical trials. It hasn't evolved with availability of new tools and techniques. And we have not realized the potential advantages of those new tools and techniques in terms of cost and efficiency because they've been absorbed by the legacy system we're operating in. At the same time, we've created a separate system for conducting clinical research that's parallel to the one we have for delivery of healthcare. I think that was touched on yesterday. And we haven't tapped into some of those synergies. So in the spirit of IOM's vision of a learning health system, we need to find better ways to bring and merge these two goals together and bring more physicians and patients into the business of knowledge generation. Now, Clay Christensen, in his book, Innovator's Dilemma, talks about disruptive innovation. And he talks about the key need to combine and marry new technology with a transformation in the business model. And it's the latter, the business model, that the new technology enables that creates the disruptive impact. Just applying new technology results in incremental change, results in sustaining innovation, but is not truly disruptive. And I would submit that addressing the infrastructure-related barriers to transforming our current business model has the potential to be more efficient and free up resources so we can do more of the studies we'd like to do. In fact, now there are many questions we have to answer, whether it's looking at a new drug, whether it's medical decision-making. We're not able to do all the trials we want to do because we have limited resources. If we can make things less labor-intensive and less expensive, we could free resources up to answer the questions we need to answer and address the needs of a larger set of stakeholders beyond the regulators. From the industry perspective, we tend to focus primarily on the needs for registration, secondarily to other stakeholders like payers, like patients and physicians. We could also study new products, as I said, and answer a lot of pressing medical questions. So by addressing these infrastructure barriers and costs, we have the potential to be truly disruptive on two fronts. Again, coming back to Clay Christensen, he talked about low-end disruption and new market disruption. On the low-end side, if we can simplify our trials, make them less costly, move them out of the high-cost infrastructure tertiary care centers out into the community, reduce the number of bells and whistles in our trials, we can create low-end disruption. If we make things more efficient and we're able to do more trials, answer more questions, and serve more customers, we can create new market disruption, what he calls new market disruption. So on both of those fronts, there's tremendous opportunity here. So that's a little bit of a soapbox perspective from my view. So what I'll do now, let me just turn and introduce our speakers who will each give short presentations. Our first presenter is Rich Platt, who I think needs no introduction, but he is professor and chair of the Harvard Medical School Department of Population Medicine at Harvard Pilgrim Healthcare Institute. He's also principal investigator of FDA's Mini Sentinel program and has contracts with FDA's CDER and CBER to conduct post-marketing studies of drugs' safety and effectiveness. He's also principal investigator, the CDC Prevention Epicenter, CDC Center of Excellence in Public Health Informatics, and an AHRQ HMO Research Network DECIDE Center. Let me actually introduce everybody, and then I'll turn it over to you for your presentation. We have Ryan Ferguson over here, who is acting director of the VA Cooperative Studies Program Coordinating Center in Boston, where he's involved in the conduct of large multi-center randomized clinical trials. He also currently serves as the program director of VA's Point of Care Research Institute. He joined the Cooperative Studies Program in 2001 and has since focused on clinical trial methodologies for conducting pragmatic comparative effectiveness research. In addition to the conduct of trials, his research interests include general clinical trials methodology, Bayesian statistics, renal epidemiology, molecular and genetic epidemiology, and translational research. Rebecca Cush is over here, and she is founder and president and CEO of CDISC, or Clinical Data Interchange Standards Consortium, which is a nonprofit standards developing organization with a mission to develop and support global platform-independent standards that enable information system interoperability to improve medical research in related areas of healthcare, and a vision of informing patient care and safety through higher quality medical research. Dr. Cush has over 25 years of experience in the area of clinical research, including positions with the U.S. NIH, academia, and global CRO and biopharma companies in the U.S. and Japan. And our last speaker is Carol Lannon. Welcome, is director of the Learning Networks Core within the James Anderson Center for Health Systems Excellence at Cincinnati Children's Hospital Medical Center. She's professor of pediatrics at the University of Cincinnati and a senior quality advisor for the American Board of Pediatrics. She's the design and implementation lead for several results-oriented, outcomes-focused improvement networks, including the Ohio Perinatal Quality Collaborative and the National Pediatric Cardiology Quality Improvement Collaborative. She's a principal investigator of a pediatric CERTs funded by AHRQ. So welcome to all our panelists. And we'll move now to the first presentation, which will be given by Rich Platt on aligning care and research to reduce burdens and improve integration.
Good. I take 3 points from our discussion yesterday as the basis for these comments. I hope this looks like part of the conversation that we had yesterday. Points 1 through 10 where you can't interfere with the normal workflow of a clinical operation. The second is that electronic health records are at a minimum useful and possibly essential for the kind of progress we want. And the third is that for many of the topics of interest that it's bigger than the both of us and that consortia will be needed to make reasonable progress. Now, there's always a but with all of these, so let me address some of the buts. The but with can't interfere with workflow is that trials, there is no trial unless somebody changes something, and so you have to think about who would do that. The second but is that for EHRs, we had plenty of conversation yesterday about the fact that EHRs are difficult to use for research. The clinicians will say they're difficult to use for clinical care, but that's not our problem right now. The thing that I think we didn't talk so much about is that EHRs by themselves are rarely sufficient for the needs of a large, simple trial. And And some of the things that we said about the consortia, but not very loudly, are that they're expensive to build and maintain. There are substantial barriers to the kind of sharing of data that's required for a consortium to operate efficiently. And aside from those barriers, there are formidable governance challenges. So I'd like to spend the next few minutes talking about at least some ways that we might look to infrastructure to help ameliorate these problems. So starting off with the fact of how you deal with the workflow situation. Well, minimizing interference with operations really means that some managerial time and systems are going to have to be allocated to support a trial in order to avoid what we were really talking about, which is impact on frontline personnel. And that can be done in a variety of ways, but we need to address that. I think part of what I took from what Alan Goh and Elsie Tavares said is that clinical organizations will, if they're thoughtful and have enough time to breathe, say it's worth our while to allocate leadership time to making these changes. But what Alan said was, in order to get on our list of things, you have to be proposing something that's really of interest to us sort of in the near term. Otherwise, there's going to have to be an investment in that. Let me just give you an example. My colleagues and I recently completed a large, simple trial, a cluster randomized trial of 75,000 patients in 43 hospitals that belong to Hospital Corporation of America. I think by every measure that we apply to pragmatic trials in the learning health system, it meets those criteria. The all-in cost for completing a study of this many people was just under $3 million. $2 million of that was checks that the taxpayers wrote through AHRQ and CDC. The other $1 million was in-kind and out-of-pocket contributions by Hospital Corporation of America, which was the environment in which we did this. And who participated from the Hospital Corporation of America? All of the frontline staff knew that there was a trial, but they were doing their normal activities, so they didn't get slowed down at all. On the other hand, there was meaningful participation by, I'm giving you a sample of the managerial structure that was intimately involved in planning and executing this trial. They were involved in the conception, in the rollout, and in making sure that it actually operated. I think that something like this is going to be needed for any organization that participates in a meaningful way in large, simple trials. And so we're going to have to understand in whose interest is it to fund the existence of the time. It's not even putting new people in the system. The only people who could do this are people who are intimately familiar with the way the system works. And so there has to be enough resources to make this a workable system. Okay, moving on to EHRs. We talked about the fact that each AHR is different. Each installation of Epicare is different from every other installation of Epicare. And so a way to deal with that is to take the information out of the EHRs. This is an example, a system that we built with support from the Centers for Disease Control that we call ESP, because it was built to support public health uses of electronic health record data. And quite simply, what happens is every night a substantial amount of information is downloaded from the EHR onto a standalone server that's behind the organization's firewall. So there's no HIPAA issue involved here. But the data are then, so several good things happen. One is the data can be transformed and manipulated at will. And secondly, we're not burdening the EHR system. And thirdly, it's EHR agnostic. And then you can run whatever algorithms you like and create whatever kinds of reports you like, subject to the consent of the organization and the approval of the IRB. What I'm showing here is reports that can be line lists, that is data sets, or they can be aggregated reports that can go to a research team. In fact, we built this to do public health reporting. This is the largest single source of clinician-based reports in Massachusetts, has been for the last 5 years. So it's workable to get information out of the systems. It's harder to get information back into the EHR, and that's been a pitched battle, but we've at least wrestled it to the ground for Epicare systems to be able to send structured queries back into the system to be able to engage clinicians in trial kinds of activities. On the rarely sufficient front, remember that an EHR is basically a system that lives inside of a practice or a hospital. And so it knows a lot about the care that's delivered by that organization. And typically it knows nothing about care that's received outside that organization. So that to the extent that a large simple trial involves randomizing patients to treatment A or treatment B in an ambulatory setting, and the follow-up that's of interest occurs with a hospitalization, an EHR is going to be severely constrained. And so our approach to that is to marry EHR data to other kinds of data, and I think the prime candidate for that is administrative data, which we didn't talk about at all yesterday, and I think we're missing an opportunity because there's an enormous amount of otherwise unavailable information that's absolutely essential for the kinds of studies we're talking about. For most people who are insured, administrative data knows about meaningful care that's delivered across the entire spectrum of healthcare locations. It's available for large populations, and it's better standardized than most EHR data. It's most useful when it's linked to EHR data. And here's an example of the way the FDA Mini Sentinel organizes that. The platform is administrative data, so that, that has the elements that I show here. We add to that electronic health record data when it's available. It isn't available for the majority of people, but when we have it, we have height, weight, blood pressure, temperature, and laboratory test results. Even that isn't enough. There are some things for which you need data that comes from registries like immunization registries, birth and death registries. Having done that, there's now a functional data set that the FDA asks us to query on their behalf on a weekly basis that has large populations with well-defined person time, for which we have reasonable confidence that we've got good capture of certain kinds of events of interest. There's data like this for 126 million people, for hundreds of millions of person years, billions and billions of dispensings. And it's possible to use this as a platform for a wide array of activities. FDA's position about this data set is that it should become a national resource, and I think that's one of the challenges that we have, is to think about how to do that. Not as a standalone, by itself, self-sufficient, but as a platform on which to build additional capabilities. Let me close by talking about the challenges and potential benefits of building consortia. I don't have anything smart to say about the fact that they're expensive to build and to maintain. I think that's going to be a fixed cost, which is large if you're personally writing the check. It is small compared to even a single one of the Rob Califf trials that we talk about. But I will talk about the barriers to data sharing. This is Farzad Mostashari saying, the Office of the National Coordinator's view about the way to share data is to keep the data and share the information. Send the questions to the data. And so we've been happy to work with ONC in thinking about ways to do that and building distributed networks that allow an authorized user to submit a question through a secure portal to an organization that has data that's been arrayed in a format that asking the question means send a program. And that program will operate on the data. That's the way the Mini Sentinel works. And it will return an answer. And that answer is almost always free of PHI. Sometimes it has PHI, but it has a lot less protected health information than exists in the whole data set. It also alleviates the problem of sharing data that is considered proprietary, even if it isn't PHI, or data that an investigator has some ongoing interest in using. So here's the piece that I just said. The fact that the data holders have control over the users and the uses of their data makes it a lot easier to agree to participate in specific studies. That is, many people will agree to participate in a study when they wouldn't agree to hand over their data for the same study because of real concerns about the downstream potential uses that they might not be able to control. There are lots of examples of distributed networks that are up and running right now. I've listed a few here by their sponsoring organizations. One of the things that's most important to note about this is that it's possible for a single organization to have the same data set be represented in multiple distributed networks. And so the ability to do mix and match, I think, provides the opportunity for extremely efficient reuse of data and networks. So here's a schematic of some health plans and some hospitals and an outpatient clinic, and AHRQ stands up a network that uses data from these organizations. So the list I gave you on the last slide is sort of the prototype for these. And then the Mini Sentinel uses many of the same organizations' data, plus some others. And the NIH has yet other superimposed but not completely overlapping networks. The advantage of these is that each organization can choose to participate in multiple networks. Each network controls its own governance and coordination. So the same data set, the same organization is made available to FDA under completely different rules than it is to NIH. And that suits everybody's needs pretty well. And yet, you can share the costs of the infrastructure, the data curation, the things that make it expensive and difficult to use. Here's a cartoon of the it doesn't exist yet NIH Distributed Research Network, but we're planning to build it as part of the Healthcare Systems Research Collaboratory that NIH has just funded, that Rob leads, and my team has the charge to make this real. But the key concept here is that the Distributed Research Network will have the ability to make accessible through a single portal any data set that any organization chooses to make available. I've shown here the Mini Sentinel data set, the HMO Research Network. These demos are the projects that, the demonstration projects that NIH has funded. It's all voluntary. An organization can make its data available for one project, but not another, or for no project. And the fact that there is complete autonomy from project to project makes it easy to make the data sets available, at least in principle. Okay, thanks. I appreciate your time.
Thank you, Rich. We're going to hold questions until everyone's presented. So we'll move on now to Ryan Ferguson, who's going to talk about point of care trials using EHR platforms.
Good morning. I plan to present a slightly different take on the large simple trial, and it's how the VA, and in particular the Department of Veterans Affairs Cooperative Studies Program, is envisioning the large simple trial and how we are starting to implement them across the country. I'll dispense with the introductions because John did such a great job. I feel like I should bring you to my promotions committee at the university. But this should be no real surprise to anyone that within the VA, our evidence creation was becoming inefficient, both in terms of our resources and the time to a product. And more importantly, though, the research and development enterprise that existed within the VA was not meeting the needs, and in particular the healthcare system's information needs, because it was really ramped up for basic science discovery and for drug discovery. It was not tuned into clinical effectiveness or comparative effectiveness. And so what we had was two asynchronous worlds, one of clinical care and one of research, that were operating independently and rather intolerantly of one another. Coupled with the fact that the financing for both of these groups was not aligned with the information needs, we had a problem with having scalable comparative effectiveness research. So our solution to this is to create a learning healthcare system within the VA that conducts large, simple trials within the electronic medical record of the VA. And so what we have is we have a system that identifies its own needs, it uses its own infrastructure, and then it uses the research methodologies and expertise that it has in-house with statisticians and epidemiologists like myself. It asks its question, and then it answers its question, and through the use of the EMR and decision support services, it directly implements the research into practice so that the knowledge that we gain is turned directly into care. Every time that we do a study, we improve ourselves and continue on. So here is a schematic and a definition of what we call the point of care clinical research program. It is a clinical trial with to a maximal extent possible, the operations and the entire infrastructure of an RCT placed into clinical care, such that during the course of routine care, patients are randomized to one of two choices and say drugs if equipoise exists. So we are taking what Dr. Lauer talked about yesterday to an extreme where each healthcare encounter within the VA, or at least we hope each healthcare encounter within the VA will be turned into a learning exercise for the VA such that we can improve ourselves and improve the care that we're delivering to the veterans. And so the normal randomized clinical trial workflow that we're all familiar with, the identification, consent, randomization, intervention, and follow-up are all done within the VA's homegrown electronic medical record. I'm going to show you a little bit about that. And to satisfy the statisticians among us, we are using a hybrid approach using both Bayesian and frequentist statistics such that we have what we call adaptive learning. We're using Bayesian statistics to adjust our randomization probabilities. We're playing the winner, so to speak, and we're also using conventional statistics to evaluate our evidence. This allows us to promote automated implementation of the winning strategy. As drug A starts to beat drug B, that drug starts to come up more and more frequently, and as we, the controllers of the EMR, we can shut off drug B once it starts to lose and drug A's evidence starts to swamp it. Clearly, I think there are some advantages to point of care. Point of care is pragmatic in nature, and because of that, it addresses the clinical effectiveness of the VA's care. It also has the ability to assess long-term outcomes because our veterans, once they enter the system, stay with the system for a large part. And we can also get data from outside the VA through data sharing agreements with places like Medicare, and so we have definite long-term follow-up on our patients. And I'll show you some data from our pilot study in just a second. More importantly, though, I think that we have the ability to immediately integrate our results into practice, thereby lowering the T2 translation barrier that we're all familiar with. We'll have enhanced acceptance by our providers because they are the ones that are actually going to be participating in the generation of the evidence. They'll be more likely to believe that evidence, and hopefully they'll be more likely to use that evidence. We'll also have adaptive randomization and conversion, as I mentioned, using decision support. So this gets to improve the logistics within the clinical trial realm because we'll get the speedy answer and we'll also get the speedy use that we discussed yesterday, excuse me. So let me talk to you a little bit about the pilot study. We did a pilot study to see if this was just a pipe dream or if we could actually conduct a large, simple trial within the EMR. We wanted to know if it was possible to modify the EMR screens to do randomization, to see what the data quality was, and whether or not we had a sufficient ability to use informatics tools like natural language processing and the like in order to abstract the data that was not structured. We also wanted to assess acceptance. We wanted to know if patients, if providers, and if the regulators would actually go for this. And we wanted to, all the while, settling a substantial clinical issue for the VA, and we wanted to demonstrate the fact that we could close that implementation gap. So we did this within the realm of insulin administration. There are two accepted forms of insulin administration within the VA. One is a sliding scale, the other is weight-based. One uses long-acting and fast-acting insulin. The other just uses long-acting insulin. And there was little evidence to support the use of one over the other. And when we queried, just anecdotally, our providers, they told us that they preferentially administered one over the other because that's what they were taught when they were students and interns. And so we conducted an open label randomized controlled trial of these two regimens at 3 VA medical centers across the country, typically just in the Northeast, actually, not across the country. We did it in inpatients who were not admitted to the ICU, and we had very broad inclusion-exclusion criteria. In fact, the only two of note were that if you were to stay on your home-based insulin regimen, which is typical, then you were not eligible for the study because we did not want to perturb that. And also, if you could not give informed consent, clearly you could not participate. The endpoints are a little bit different than what you would expect. Our primary endpoint was really aimed at getting at what the critical question was for the healthcare system. It is length of stay. Does one insulin regimen affect beneficially the length of stay over another one? And our secondary endpoints were those that you would normally consider: inpatient glycemic control and then readmission within 30 days. We made no changes to the typical sliding scale or to the weight-based regimens, and we interfaced with our clinicians entirely through Vista. This is what the first screen looks like. Typically, before our study, you would just see weight-based or sliding scale insulin. Now they have the option to randomize and then to tell us that they have no preference. If they select that they have no preference, this is the screen that pops up. It explains a little bit about the study and then says, yes, please approach my patient, or no, please do not approach my patient. If they choose yes, then they're brought to this screen that automatically randomizes the patient and inserts a note into clinical care. Some interesting data that we found qualitatively: our providers resist change, as you would expect, I think. They resist change to the EMR, they resist change to the workload and to the workflow. However, all of our providers accept the method if they are engaged in it. If they are taught about the method and if they are explained why we're doing it, then we had no one refuse to participate. Our patients accept the method widely as well. And in fact, we found some interesting things that they don't necessarily worry about the things that we think that they worry about as researchers. From a quantitative perspective, our data quality was hypervariable. And it depended upon whether or not it was structured or not structured, which is something that I think comes to no surprise to people here. Our acceptance rates were high, both among regulators and providers, and our participation rates were very high. We track the rates of declining participation for all of our clinical trials, and the rates for declining participation in this clinical trial were 1/5 that of our normal LSTs that are run using the typical, RCT infrastructure. We had no losses to follow-up, no death, and no safety events. So, what are the take-homes? The take-homes, I think, are that we have to ask the right question for the healthcare system. It needs to be driven clearly by the clinical side of the house. And in fact, I put that in quotes because I no longer think that we should consider ourselves as having two sides of the house: the research side of the house and the clinical side of the house. If we are to be a learning healthcare organization, that represents backward thinking, and we need to think of ourselves as one merged unit going forward. And to the question that most people want me to address, is it possible to use the EMR? And I think the answer is yes, it is possible to use the EMR. Good, meaning usable and interpretable data can come from the EMR. It is not an illusion. In fact, we had few technical problems with the adaptation of the screens and the order sets in order to do our LST. We did have some issues with governance, meaning access and permissions, and the structure of the data, as I mentioned before, caused some data quality issues, but those were not something that we couldn't overcome in order to conduct these in the future. This, I think, is the real problem. And this is the disparity between financing and the proportion of the budget that healthcare R&D is, that we have for healthcare R&D versus spending in general health costs. If we don't fix this somehow, if we don't merge these two and consider ourselves to have one aligned goal with the healthcare system and the research and development system, then I think we will be doomed for failure. We do have some other cultural barriers. Patients have a hard time believing that doctors do not know what is best for them. Our doctors have a hard time believing that they do not know what is best for their patients. Our IRBs have a hard time believing that patients want to participate in a study without signing a 25-page consent form. And our statisticians, well, we just do not believe. We are confronting a Freerider Dilemma where those that use our healthcare system demand evidence-based medicine, but very few are willing to be a part of that evidence. I think some of our preliminary results coming from our focus groups would actually show that this is not the case. Our patients are willing to participate in controlled trials. We just have to lower the activation energy for them to get into the trial. So if they're simple, if there's minimal workflow and workload on them, they're willing to participate, and so too are our providers. So what do we have to do? What are our priorities? Clearly, we need to rethink the relationship between clinical care and R&D. We need buy-in from the clinical side, and I think we need a next generation EMR so that we can have more sophistication with the types of clinical trials that we do. And in fact, some sort of app-driven approach would, I think, be ideal. Next steps within the VA, well, we're finishing our focus groups and surveys, and we'll be publishing those results later. We have 3 additional use cases in the pipeline. One looking at second-generation anti-protease inhibitors. We're looking at the area of blood pressure control, comparing hydrochlorothiazide with chlorothalidone, and we're looking at 2 different types of mental health approaches. In terms of consent, I know this was an issue that we brought up yesterday. In the pilot, we consent every single person, but we're moving towards pre-consenting a population such that at the time of admission, people would be consented to the point of care program, and that as they hit the decision nodes, they would be randomized. So the bad news is the healthcare system is inhospitable, intolerant of, and unmoved by experimental research. And I think that the good news is that the healthcare system is unaffordable, unsuccessful, and on the verge of collapse. And so we need some tools, and I think the point of care tool is likely to help us overcome some of these. So just acknowledgements of funding and the point of care team. Thank you.
Thank you, Ryan. We'll now move on to Rebecca, who's going to talk about getting to comparable computable data.
Can you move it to the first slide, please? Going backwards through the talk here. Great. So I'm very pleased to be here today, and I thank you all for inviting me. And my presentation topic, which I didn't pick, but I wouldn't have picked a better one for what I wanted to say here, is infrastructure needs getting to comparable computable data. So I thought I should start here, which a number of you have already discussed this, but I think a picture's worth 1,000 words. And this is of a busy clinical research center in Nebraska. And unfortunately, a lot of clinical trials are actually still done on paper, 3-part NCR paper, where pages are left at the site and other pages are brought in and the data are re-entered. And my question when I look at this, first of all, you see all the paper and all the notebooks, and then you see a few laptops. And I know when my colleague went to visit one of these sites and said, you know, why do you have 3 laptops there? And they go, well, the other 6 are in the back room because we didn't have room for them here. And every one of those requires a different login and a different way to enter the data and a different way to fix the data when something's found that's wrong. And it's just, this is the problem. And then I say, you know, where is the EHR in all of this? And it's probably in another room. So we still have this huge problem. And I thought the best thing I could do was to go through the body of work that's been done over the last 15 to 20 years to tee up a way to address this, and then ask what we need to be doing to do this disruptive activity that John Orloff discussed when we started this session. So this is a list of things that are available to do something disruptive, to make a change, and yet they're really not being broadly accepted or implemented. So I'm not going to have time to describe each of them in depth, but I would like to go through each of them and just introduce what has been done in these areas. And this has been done actually through a few CDISC initiatives that have been collaborative with a lot of other people around the world to affect the way that we do research globally. So this is a concept that we had in 1997, and my colleague and I drew this diagram because we thought, you know, if we didn't have to enter the data on paper first, what could be the benefits? What if we used Esource? And Esource is defined as being that the data are collected electronically and never go on to paper. And this is a concept that at the time was pretty radical because everybody thought, but you have to have a source document on paper so that when an auditor comes to the site, they know where the original data are. But this was, we thought, if you could have eSource and that was acceptable, you would be able to automatically reconcile the data between the healthcare and the electronic case report forms. So we drew out some process maps. These were actually published in a book that Ken Getz published when he was leading Center Watch. And he told us we should really have a book about e-clinical trials. And what you can see on the top is this is the process for a paper-based trial, and this is what happens at the investigative side and then what happens in-house at the place that's the sponsor for the trial. And if you can collect data electronically at the source and never put it on paper, you see the change in the number of steps that it takes to do that process. And I'm not talking about electronic data capture because that data are typically collected on paper first. This is truly eSource. So we went forward and we were talking with some people at FDA and Department of Scientific Investigation, and they were actually trying to encourage the use of e-diaries because they found that paper diaries, people would fill them in after the fact in the parking lot when they come to their visit, or in some cases pre-fill them as if they thought they could predict how they were going to feel the next day. So they said we could get better data if we could use electronic diaries because we can track the audit trail on when that data were actually entered and it's more accurate. So they actually asked us to put together a task force and say, get a multidisciplinary group to look at what if we could facilitate the use of eSource but still keep the regulations because it would take too long to change the regulations. And so the overarching goals were A, how do we make it easier for a clinician to do a clinical research study? And how do we collect the data once and only once and use in multiple ways? How do we make sure that we're doing this in a way to improve the data quality and patient safety? And those were the goals. And we worked on this with a group looking at all the regulations around the world and the good clinical practices and the ICH requirements and what are required for data around the world. And we came up with a set of 12 requirements. And these are requirements that you could follow any kind of process. You can use an electronic health record or an e-diary or whatever, but use Esource. And how could you make the process work and still follow the regulations that are required around the world for regulated clinical trials? So there's 12 requirements for Esource. We came up with some scenarios and we put together a document that is still posted. The document goes through all of the background and all the mapping and how we came out with the requirements. And this is actually called the Esource Data Interchange document. And you can get it off of our website. And it paved the way for what I'm going to talk about next, called the retrieve form for data capture, which is a workflow improvement process. So the other thing I wanted to mention is that during the course of all of this work on the eHealth and Healthcare Link initiative, we were developing standards that we could use for regulated clinical research or other kinds of clinical research. And this is just a dashboard that you can find on the website because the standards are freely available and open. And what you see is these standards cover from planning through data collection, through data tabulation, and then statistical analyses. And these two right here are the ones that the FDA has been giving a lot of input on because that's how they need to see data that are aggregated in tables and analysis data sets to really review a new application for a product. But the ones I wanted to mention today are CDASH, ODM, and then our Healthcare Link initiative, and those are the ones that I think are applicable today. What happens a lot of times is people try to map into these standards after the fact, and then you lose a lot of valuable data, then mapping never really occurs right, so we keep trying to encourage to implement the standards up front and collect the data in a format that will then pave the way downstream. So CDASH was actually developed through the Critical Path initiative that Dr. Woodcock put together. She was one of the key authors of that. I know Rachel's here and she runs the Critical Path programs at FDA, but this is one of the opportunities they identified, which was how do we make it easier for a physician to conduct clinical research? And how could we come up with a core set of data that are common across all clinical trials that would allow people to make it so that the case report forms are common across these trials and make it easier again for clinicians to enter the data. So CDASH is actually a core set of data elements that are common across all clinical trials. There's 18 domains were put together initially. This was a 2-year project and we got a little bit of funding for it and provided a project manager. All the rest of the work was done through volunteer work in everywhere, Europe, US, China, Japan, all the ICH areas, and this is the product of that. So CDASH is one standard I'll talk about in the context of this interoperability specification. The other one is ODM, which is actually transport standard. It's XML, and it was designed to carry data that come from case report forms. It was specifically designed to make sure to adhere to the regulations and good clinical practices because it has a built-in audit trail so that if you change the data, you can track all the metadata on who entered the data, whether it was changed, if it was changed, who changed it, why, and when, and what did they change. So this is the ODM and the audit trail, and that'll hopefully become clear in a minute when I describe why this is important. So back to what I was talking about when I said that the eSource data interchange document paved the way for retrieve form for data capture. We worked with Landon Bain, who was the CIO at Duke for a good while, and at the time he was still there. At the moment he then resigned and retired, and then we talked him into coming back and working for CDISC. So he's in charge of our Healthcare Link initiative, and we did this project called Single Source with Duke because Duke Clinical Research Institute was doing academic research, and Duke University Medical Center hadn't pulled a paper chart in about 3 years, and yet they were filling out these case report forms on paper and taking them back to the clinic. And again, this is quite some time ago, but the doctors were saying, oh, we have to fill out these case report forms, so they would fill those out first and then go enter the data into the medical record. So Landon noticed this is really not appropriate because now the Esource is actually the paper case report form and not the medical record. So we did this demonstration and worked with integrating the healthcare enterprise to develop this retrieve form for data capture, and it allows you to take a remotely managed electronic case report form managed by the sponsor and pull it actually into the EHR environment so that the physician can do their own workflow, and when the patient enters into the trial, the case report form will pop up and the EHR will pre-populate any fields that it has the data for that it can pre-populate. Any other data that you need for the research, because you're not ever going to find all of the research data in the EHR, can then be entered in, and the case report form data can then go into the EHR and also back to the sponsor. So this is called single source. Enter the data once, it goes into the EHR, and it goes to the clinic. And this one was done in a way that Landon would tell you was duct tape and baling wire, and it just basically proved a point, and it was a pilot. But it has gone on to become quite a mature, what they call integration profile. And then I was talking to Elaine before we started, and she said, you know, there was a lot of work that we did through HITSP and through that ANSI program. And this is, I'm giving you the whole history, 15 years. In about 2010, when HITSP was involved in creating use cases for how the EHRs were going to use the information and how we were going to use that information from EHRs, we kept saying, what about research? What about research? And about 2 years in, they still were saying, well, that's not top priority. That's not top priority. And finally, right before HITSP, the very last use case that they accepted was research. But they didn't have any money to contribute to it, so we actually had to raise the funding. ANSI put together a group to talk about how we would do it and what would be the use case. And that group decided that we should identify a common set of core research data elements that can really be exchanged between EHRs and clinical research. And that was the use case. And there were a lot of people involved in this. I'm just going to flip through these real quickly. This was the work group that was put together to come up with the use case. And all of these groups contributed funding to make this happen. And so a lot of effort was put into it, a lot of contributions. There's another page of this. There were government funding groups, there were academics, there were pharma. They all wanted to see this happen. So this is the result. And the RFD was a piece of it. So what we ended up with was an interoperability specification, number 158. It's posted through HITSP on the ONC website. It was done with the Department of Health and Human Services, ONC, and ANSI. And it uses what's called the Continuity of Care document, or they call it C32, which is a common set of information out of the EHR, de-identified, and they map that to C-, and then RFD is the workflow component that brings the form in and allows it to happen. And so what we ended up with was an IS that can produce a standard core research data set. It enables 21 CFR compliant regulated clinical research, interoperability, and Esource. So this was actually demonstrated in a number of places, and it's been used in a few cases. What it does is it allows you to take the EHR and put it in the middle, and then you can eliminate all of these other computers that you're re-entering data into, and you can then produce information for public health, safety, clinical research, and quality. And there's still a group at IHE that's producing more integration profiles called QUIRF, Quality Research and Public Health. And we ended up with actually then 4 interoperability specifications that make use of the RFD. And some of the studies that were done, there's some being done in Europe and one by Greenway Medical with a phase 4 study using the RFD for research. The CDC used the RFD for reporting swine flu, H1N1 outbreak reports. We have a safety study that I'll show you a little more data on in a minute that Pfizer did with Harvard, and they're also using it in Japan for safety. And there was a possibility of mapping this to quality measures. I'm not sure it's going to happen because that work had to happen so quickly. But these are some of the trials of RFD that have been done. And there has yet to be a regulated research study done using RFD. So ASTER, which was the adverse event work that was done with Pfizer, what they did was they used the EHR that was at Harvard, and they took 30 ambulatory care physicians. They said, when you discontinue the drug, a form will pop up, and this is the form that's used for reporting adverse events to the FDA, and they pre-populated the form with the data that were needed for that report, that adverse event report. So these clinicians who had, most of them, never reported an adverse event because it's not required on a marketed drug for them to submit this, during this study, because it was reduced from 35 minutes, which you all know is time to see another patient or two, down to less than a minute, they started doing this. So the workflow improvement was dramatic because it was right in their face. It was pre-populated. They entered a couple of pieces of information, and it was sent. So this is the ASTER reporting. And the beauty of this is that actually you can use the RFD in a number of different EHRs. So different sites can have different EHRs. You don't have to use the same EHR. And if a site doesn't have an EHR, you can use EDC if that's what they're using. You can use paper, and you can take CDASH, and all of these could be 4 different sites doing the study different ways. They can produce a CDASH data set, which is a common standard, common research data set in standard format that's ready to go into an operational database and ready to go into SDTM, which is what the FDA is now using. In the meantime, the EMA, European Medicines Association Agency, did a paper, and they now have a guidance for their field auditors to audit for Esource, and it references the requirements from the ESDI paper, which formed the basis for the RFD. And just this month, the FDA came out with the new version, draft guidance for Esource. And it states right in the guidance, this guidance promotes capturing source data in electronic form and is intended to assist in ensuring the reliability, quality, integrity, and traceability of electronic source data. So there are still people who fear that the FDA doesn't want you to use Esource. And I think this is why this is so clearly stated, that this is to encourage the use of Esource. And it says capturing Esource electronically should help to do these things. So it's out for public review now for 90 days, and I'd encourage you all to look at it. In the meantime, CEDA's Healthcare Link and Landon Bain with the core committee at IHE has put together these additional profiles. Some of them will use the protocol standards so that it can automate the visits in an EHR for a patient doing clinical research. Some of them address how to do the documentation and how to make sure that the mapping occurs. These around confidentiality and security were done at the request of FDA's Office of Scientific Investigation. And so these are all available. These were just approved last month, and one is actually an app to go into a clinical EHR to say, do you have patients in your EHR that match these eligibility criteria? So that one's in progress. So this is all teed up, and this is a reminder slide for me to say that actually this is what's happening on meaningful use, and the use of EHRs is increasing around the United States, and there are checkpoints, and if we're not there and saying, you know, where's research in all of this, we're going to get left behind, and there will be a path that will diverge between what's going on with EHRs for meaningful use and what we need for research. So I think we all need to be at the table for that. And to conclude, I'd just like to say that we had done so many demos with RFD, and we'd done tests, and there were pilot projects, and I finally said, when is somebody going to do the real thing? when is somebody going to do a trial using the interoperability specification for a regulated research study? And so we stood at DIA this year with Doug Fritzma from the Office of the National Coordinator, HHS, from people from the FDA, people from one of the EHRs that was saying all of these EHRs can do this, why don't you try it? And they, use it in a regulated trial. And we put a challenge forth in June, and we're still waiting for somebody to take the challenge. And I just say that these capabilities are available for using all of the things I talked about to streamline the way that we do clinical research using EHRs in a standards-based way to produce standard computable, aggregatable data. It dramatically reduces the time and effort that a clinician needs to take to give that kind of data. It can pre-populate case report forms or any kind of forms for adverse events. It can accommodate e-diaries. It's been shown to improve data quality. And again, you can readily aggregate this data. You don't have to do remapping and everything else, and it's extensible. And the EHR Association has endorsed this. They wrote a letter. It's on our website. They said it's very easy for EHRs to implement. Most of the common EHRs have implemented this. And I said, enough demos, when are we going to do the real thing? And I'd like to open up the floor for discussion on why this isn't happening and why there's not broad uptake on some of these things, or are they too disruptive and people are afraid. So I'd just like to say that this cycle has been said to take 17 years for research results to be put into actual practice, and that's far too long to wait. So thank you very much.
Thank you, Rebecca. That was great. We're going to move on to our last presentation now. Carol Lannon will talk about building reusable research networks.
Thanks. Good morning, and thanks for the opportunity to speak with you today on reusable networks. This is a term that is used to describe data that's used for more than one purpose. I'm going to expand on that a bit and highlight how networks can also be reused by various stakeholders and also to answer various questions. The learning healthcare system, it's really an honor to speak in a setting that's focused on this. My colleagues and I at Cincinnati Children's really aspire to develop learning healthcare systems, and I'd like to tell you a bit about what we're doing. Our Learning Networks core at Cincinnati supports 5 networks in 119 locations, including 38 CTSA sites. These networks include one focused on patient safety, one focused on perinatal, both obstetrical and neonatal, collaborating together, and then 3 which are disease-focused. The work I'll be presenting today, I want to acknowledge several colleagues, Steve Muthing with the Safety Network, Peter Margolis and Michael Saylor with Improve Care Now, and multiple, too many to mention, senior clinical leaders from across the country and the state who are involved with us on these, as well as the patients, families, and clinical teams who are at the front lines. The networks are in various stages of development. Improve Care Now is the oldest, and later in my talk I'm going to be focusing a bit on that. As was alluded to yesterday, the concept of reusable networks is especially important in pediatrics, where most diseases could be classified as rare diseases by the NIH definition. In designing, developing, and implementing the networks, we've adapted the Institute for Healthcare Improvement Breakthrough Series methodology, and that means that we bring teams together in face-to-face sessions, usually twice a year. We talk together once a month through webinars. We give data feedback monthly in real time so people can see how they're doing and implement changes to do that. As you all know and has been talked about today, there's incredible variation among healthcare practices. And so one of the great opportunities in using networks like this is that you have the opportunity to standardize care practices, reducing practice-to-practice variation, and really increasing the ability to detect changes. One of my colleagues says that similar to a biology lab, we're creating reagent-grade practices to work with. There was also a lot of discussion yesterday about incentives and challenges for participation. Some of the incentives for engaging clinical teams here are that by participating in these networks, the pediatricians receive maintenance of certification credit from the board. That's been important. And for several of the networks, by inputting data in these registries or the databases, they receive U.S. News and World Report credit for those best hospital rankings, which has been important for some of the sites. This slide just shows some of the results, and I recognize that it's small. In the upper left, there is data from the 8 children's hospitals in Ohio showing how there's been a significant decrease in surgical site infections. In the upper right, that's from Improved Care Now, focused on pediatric inflammatory bowel disease, showing an increase in patients in remission from about 55% to 75%. Some of the sites are now at about 80%. In the lower left, this is birth certificate data from the state of Ohio, and it's looking at the 20 largest maternity hospitals, which account for half of all births in Ohio. And what we did was work on decreasing scheduled deliveries between 36 and 38 weeks without medical indication. We've worked with state vital statistics so we can actually give data back monthly to sites on this, and they can also use their own data to track that. Over time, this shows that things were fairly stable for 2.5 years before we started, and then the dip begins shortly after we started. In the 4 years since this has gone on, the state Medicaid estimates that we have shifted over 25,000 births from preterm to term, saved 500 NICU admissions, and probably $20 to $30 million for the state. And then finally, in the last slide, this is data from the pediatric cardiology network looking at the 16 initial sites that were participating and variation in growth for babies with hypoplastic left heart between the first 2 surgeries at 1 month and 6 months. And there were some sites where every baby grew and other sites where there was stability or weight loss. And so this is an example of knowledge generation where we were able to identify what were the factors associated with growth and are now spreading that throughout. I'll just mention that the safety grant or the safety project has now received a grant from CMMI, and in these 2 years is spreading to an additional 75 hospitals throughout the country. I wanted to note that we use quality improvement as a basis of what we do, and in a July meeting of PCORI, Rich Glicklick noted that registries that have higher likelihood to constitute long-term infrastructure are those with at least one purpose, being QI. One of the things we're doing at Cincinnati, and we call it learning networks because we're learning all the time from the 5 networks that are going, is trying to really figure out what's the maturity model for a network like this. There's a design phase. We start out with, let's see, I think there's another, there we go. There's a known amount of time to establish a project at the beginning, an investment in technology, organization, and processes. And then we're learning about leadership engagement, how to scale and spread, continuing to engage teams over the long haul. The sites in the inflammatory bowel disease network have been participating, the early sites, for over 4 years. So how do you keep sites engaged and interested in what's going on, reducing transactional costs and financial sustainability, all things that we're looking at. Oops. How do you create then a reusable network? We've heard some incredibly terrific presentations already about the data structure and quality. Our group has thought about this and come up with four ideas that we think are important. One is a focus on outcomes, and we find that this really engages patients, clinicians, and researchers. So to think, what clinical health outcomes can we achieve? And we actually engage the clinicians in determining what the topics will be. Building community is really important. I'm going to spend a little time on that. I'm going to end with talking about the effective use of technology, and then the foundation for all of this is a learning system using system science, QI, and various types of research, including qualitative. So when we think about focusing on the outcome, this is putting the patient at the center. And in this one, from the Inflammatory Bowel Disease Project, this is a little girl who is uncomfortable, in pain, and it's because she has inflammatory bowel disease. She's not feeling very well. And the focus of the network is to improve her health. Those who are working on this are the clinicians, parents, here's her mom, and also, oops, there's a researcher who's supposed to show up there in the corner. There he is. Sometimes they're missing, I guess, briefly. So that's right, they were in meetings, so he's coming in now. So what's really important for us, one of the things we found is both that we're all keep focused, our eye on the prize of improving child health, and in building a community. So these are reusable not only for data, but for the needs of those involved. In terms of building a community, I would say we're learning how to do this, and we're learning with our stakeholders. I've mentioned that we have a compelling purpose, that there is core leadership that's provided by the patients, the clinicians, and the researchers. It involves telling stories, and that everyone has many ways to contribute. In the upper right corner is Jill Plavinsky. She is a college student with inflammatory bowel disease who's actually heading up the patient advisory committee for the Improved Care Now network. Some of the shots from the lower right are from the cardiology network, where there's a Facebook site where patients and team members connect. A slide from the website where the parents have started and developed tools with the between the parents and the clinicians. And we've really found ways to engage parents. Parents are in our research work groups, are in our meetings, and in the cardiology network, we've actually begun in the last few months to invite parents to all of our calls. And it's a little bit tough because you're sometimes talking about data where you're not doing very well, or you're talking about data about mortality. And so we're learning from our parents about how to do that. I wanted to share this. We also talked about incentives yesterday, and one of the cardiologists from Atlanta wrote me this summer about a tool that she was working on, and she said, "I've learned more about the needs of parents during the few years of the collaborative than in my previous years of clinical practice." And this is a person you would love to care for your child or grandchild. So I think this is an incentive when you bring together all the stakeholders that maybe isn't always talked about. I'm going to then show a few slides about Improved Care Now, which is the oldest network that Cincinnati supported, began in 2007, and now has 48 sites and over 14,000 patients. I'm going to be sharing some slides that I've adapted from my colleague, Peter Margolis. We've talked about the barriers to data collection being significant. So effectively using technology is really important to overcome these barriers and an important attribute of a reusable network. The usual process, as we've seen, is the clinical encounter happens, the data is abstracted, and then the data is entered. With a grant, an AHRQ grant on enhanced registries, we're trying to, in this network, put data in once so that it automates chronic care processes for clinical care, measurement for QI and learning, a way to improve data quality, and then to use it for research at the care center, population, and individual level. So let me show you a few ways that this data is actually reusable. These are some small pictures, sorry about that, that actually show how the data that's going in is being used to do pre-visit planning, part of the chronic care model, and also for population management. There's another one that shows how it actually has color-coded patients that are green for in remission, red for severe disease, orange and yellow for moderate and mild. So the clinician can pretty quickly see their grouping of patients and what needs to happen. The teams get individual and aggregate data, quality improvement run charts monthly. We use this for comparative effectiveness research. Part of the Enhanced Registries grant allowed us to do a simulation that estimated the treatment effect for patients with moderate and severe Crohn's disease, and also was able to replicate the results of a randomized controlled trial. We're also undertaking a factorial design, and this shows some aspects of the chronic care model, so pre-visit planning, population management, and self-management support. And a early run chart is beginning to look as though the sites that use none of these have a remission rate of about 69%, and where the sites that use all of these have a remission rate about 81%. And then this is something that Dr. Jeremy Adler, a gastroenterologist at Michigan, is using with one of the students there, a college student, where they're actually doing N of 1 trials on the data. And in this one, the girl had not actually picked up that she had had these few areas where her symptoms, her nocturnal symptoms had actually dipped, and they realized that it was when she was taking antibiotics for sinusitis. So began to test some things with that. The challenges have been mentioned this morning. I'll just note that many of the challenges are IT, but we think we've heard about how they're being overcome. There are many transactional costs, IRB, data use agreements. There's incredible variation when you try to set up a multi-site network at the local sites in how IRBs are thought about and executed. So in Improved Care Now, we're actually testing a federated IRB model. That's going fairly well. We're learning about how to do it faster next time. One of the issues is actually sometimes academic sovereignty, I might call it, as goes on. We've also talked about the challenge for the clinicians of time. And then I think as we begin to scale, we're also trying to learn how to do this for broader groups. And finally, Dr. Horowitz asked yesterday, or Wayne Gretzky always asks, where's the puck going? I think, we're thinking now about how care is now. How will it be in the future when we have some of the big data systems where EHRs can pull this out and aggregate the data, where people can use sensors to upload their data. So we have a lot of data now. We're going to have a lot more before long that's patient developed. We may be looking at, and have heard some examples about registries moving to cloud computing. And I think we will be having ways to develop what's called distributed production, where patients and clinicians are really engaged in testing quickly and seeing what works. So thanks very much for the opportunity to talk.